Now, risk stratification and treatment for patients with polycythemia vera. So first, how do we assess risk? There have been many different analyses over the years, and one of the more recent is helpful that helps to stratify these patients and identified in a scoring system the contributing factors to risk. And this was specifically around risk of thrombosis as well as risk of death. This included older age, particularly higher if an individual is above age 67 versus 57 to 66. Next, the presence of leukocytosis with a threshold of greater than 15,000. And finally, the presence of venous thrombosis. Individuals without any of these factors would be low risk. Individuals that have a point score of 3 or more as high risk, intermediate as those somewhere in the middle. Now, historically, risk stratification had been based on the presence solely of age over grade 60 and the presence of a prior thrombotic event. If you had one or both of these factors, you were high risk. If you had neither, you were low risk. We considered as well other intermediate factors, including cardiovascular risk factors such as arterial hypertension, smoking, obesity, and diabetes. We'll discuss in a bit how we utilize these risk criteria and risk scores as we determine whether or not to include cytoreduction in a patient's treatment profile. So let's go through a case to help to illustrate some of these principles. The case is a gentleman by the name of Tony, 62 years of age, referred by his primary care physician after they found him to have marked erythrocytosis with an elevated hemoglobin of 21.5 grams per deciliter and a corresponding increase in the red cell count and thrombocytosis. He has ongoing symptoms of abdominal discomfort, fatigue, headaches, and visual disturbance, and he's itching that affects both legs. Additional laboratory testing confirms clearly the erythrocytosis and thrombocytosis, but also a subnormal serum erythropoietin level. Remember, that is being a helpful minor criteria of the WHO diagnostic criteria. By PCR, he is confirmed to have the JAK2 V617F mutation. So what is the first step in treatment for Tony that now we can diagnose based on the WHO criteria? Our goals are first that whatever treatment we use is tolerable. Our goals are to prevent thrombosis and to prevent hemorrhage. And as surrogates of this, we try to control the erythrocytosis, leukocytosis, and or thrombocytosis. We ideally will reduce his disease-related symptoms such as pruritus. If splenomegaly is present, we'd like to reduce that. And in the ideal world, we will delay or prevent progression. Now, as a current treatment algorithm for polycythemia vera, I would recommend that we assess the patient's risk as well as the difficulty with their symptoms. And with all patients with polycythemia vera, we begin with a base of control of the hematocrit to less than 45%, as well as use of low-dose aspirin. We then decide on the need for concurrent cytoreduction based on the PV risk and symptoms. So in this gentleman, he has both symptoms and he's higher risk because of his age, giving him a higher risk. Because of that, we look at frontline cytoreduction, of which in 2017 includes hydroxyurea, potentially interferon in select individuals or interferon on a clinical trial. Individuals with worsening symptom burden, vascular events, or progressive disease, resistance or intolerance to hydroxyurea, will either consider ruxolitinib or an alternative cytoreductive therapy. Now, how did we evolve to these criteria? Well, first, the target hematocrit. So the CytoPV study was done in Italy, which randomized patients to a low and a high hematocrit control group, less than 45 or 45 to 50. And in this randomized study of over 300 patients, they identified that the control of the hematocrit under 45% was very important to decrease the risk of thrombosis and bleeding. Next, the issue of aspirin. There was a randomized study done in Italy with the ECLAP trial, which using 100 milligrams of aspirin, the European formulation, versus placebo, there was superior control of risk of thrombosis with the group treated with baby aspirin. So this has evolved to be the cornerstone of therapy for all of our PV patients. Now, what about hydroxyurea? It's our most commonly utilized cytoreductive therapy, and it can help to have an impact on risk of thrombosis, hemorrhage, and in some individuals, some impact on pruritus and splenomegaly. Now, our data regarding hydroxyurea are fairly limited as an older agent. Our primary data from the Vera study group with 51 patients that compared to phlebotomy alone was superior for controlling rates of thrombosis. Now, hydroxyurea can have some challenges. It can have toxicities in myelosuppression, fever, mucocutaneous symptoms or mouth ulcers, GI symptoms or dyspepsia. It can have a range of cutaneous difficulties, such as rash, hyperpigmentation. It can lead to acute pulmonary reactions. Those are rare. There is some concern, although it is controversial, whether it may slightly increase the risk of movement toward acute leukemia, and clearly is not an option in pregnancy. Now, as we assess response in these individuals, we currently utilize European Leukemia Net criteria that look at improvement in symptoms, blood counts, lack of progressive disease, and even changes in the bone marrow. And with that, we could stratify patients into partial and even molecular response. As part of this, we do utilize improvements in the MPN symptom assessment form with the 10 different items that we had identified and discussed in the diagnostic segment, and helpful both at baseline as well as tracking over time with the therapy. So I'd conclude by saying that risk assessment is the first step in determining the treatment for polycythemia vera. Conventional evidence-based treatments include aspirin and phlebotomy in all patients and hydroxyurea in individuals who are symptomatic or who have higher risk disease. It's important to be monitoring these patients for determining response to treatment, as well as to determine whether any adjustments in treatment are necessary during the longitudinal course of care of these patients.